So, good morning, Dr. Perry. How are you doing?
I'm good. How are you this morning?
Doing well. So, I'm Sheronica Perry as well, and I'm excited to have this great conversation with you today. Um, Part of this new forum is Her Health Talk, and I'm really looking to have open and honest conversations about women healthcare, how it impacts women, and then especially us in the Black community.
Absolutely.
I started this forum for experts and then just women to really share their true stories, provide information and resources to be able to help advocate for ourselves and find useful solutions that we can take into our everyday life to be able to support and sustain a healthy lifestyle. So, thank you for joining me today. And if you could just share with our audience a little bit about yourself, that would be great.
Sure. So I am Dr. Tamika Perry. I'm board certified in family medicine. I went to undergraduate at Prairie View A&M University, go Panthers, and I went on to medical school at Philadelphia College of Osteopathic Medicine, and I got a master's of public health from University of North Texas Health Science Center, and I have been in practice for well over 20 years, and I'm actually a medical director for a national company.
Nice, thank you. So, we definitely would say we have a subject matter expert in the house today.
I would like to think so.
Just before we get in this conversation, just telling you why this really pulls at my heartstrings. Advocating for myself is extremely important, and I can't imagine as an educated person with well means what anyone else without healthcare would go through. I moved from my previous hair care providers and I was pregnant. I literally went through three doctors before I
Mhm.
found a doctor that would listen to me and acknowledge what my previous healthcare provider told me that I had a high risk pregnancy. So I felt like I was not being listened to in
Right.
that regards, and it was scary. In the process of treatments, they were saying something could be wrong with my baby. They weren't sure. They wanted to poke and pry, and no one was really telling me why until I got to that third healthcare provider who also was a woman. And she just really took my concerns to heart. And she actually followed me with another high risk doctor. So I had two doctors following my treatment, and they really heard like my concerns, and I would check in with them, twice a week towards the end of my pregnancy. And so I feel like my story is definitely not unique. There are a lot of women that go through that in terms of finding a provider who's listening to them, because I was listening to my body
Mhm.
and what I had going on. So when it comes to maternal health, especially with African American women, there's a disparity. I wanted to know if you could to speak to that and some of the impact that you've seen in the medical field and what women can do to advocate for themselves, and then eventually get into the long-term effect of what happens when this maternal health is not adequately provided, and the impact that has for future generations, those children that actually leave without the proper care from hospitals and so forth, from that situation. So if we can get into Black maternal health and advocating and some of the statistics, that would be great.
Okay, cool. So, I totally and completely feel you when you gave your anecdotal, very heartfelt story. And it is not, unfortunately, unique to you. And just not in the realm of maternal health. This is just health, period. Me as a physician, I know this to be true. I know this to be 100% true. Last summer, I like to travel. I went to Thailand. I got this bacterial infection from hell, right? So I hate going to the ER. Had to go to the ER because it was just, I felt like I was dying on the inside. So I walked into the ER. It's a bunch of people in there, a lot of people who look like you and I, people yelling, people screaming, clearly some homeless people, people on drugs. But the first thing I did when I walked up to the ER front desk, it says, "Hello, my name is Dr. Tamika Perry, and I'm a medical doctor. I need help. Here's my differential diagnosis, and here's what I'd like you to test for." They said, "Yes, ma'am," and got me back quickly. But I can promise you, the course of my visit would have went differently if I would not have started with that introduction. I was in pain, I needed help, and I needed someone to listen to me. Often when I as a provider get a new healthcare provider, I never start with "I'm a physician," because I just simply want to see how are you going to treat me as a person. So as my ER course went on, there was a change of shifts. And after I said that, the ER doctor said, Dr. Perry, what would you like me to do for you? What pain medicine would you like? What tests would you like? Of course, this courtesy shouldn't be given to everyone else because, the general population doesn't know, but her actual compassion should be given to everyone else. Right.
Mm, right.
And and I'm not saying that that particular doctor doesn't give compassion. I just wanted to make sure I got it then. Right. So when I got to the back, there was a change of shifts and another doctor came back, and he was going over my lab work. And he said, oh, your white count's a little bit high. I said, well, what's a little bit? He said, oh, just a little bit. I said, a little bit like 11, a little bit like 16, which is moderate, a little bit like 20, which is really high. He says, no, what? Well, yours was 16. What do you do again? I said, my name is Dr. Tamika Perry. I'm a board certified physician. What was my white count? He said 16. I said, that's not a little, that's moderate. Am I going to be admitted? He says, well, I would. Then the conversation started to almost a stutter, because based on my
Mm,
symptoms, based on my that lab work and other lab work and my imaging, I met criteria for admission. But you were going to send me home. Now,
yes,
I
you
opted to
are.
go home because I could treat myself at home. But once again, that's not. What if I was an accountant? What if
Mm,
I was an attorney? I would have known these things, right? Then I could have went home and got septic. So when I tell you, and I know this isn't the scope of this isn't all about me, but it's all about us, right?
right.
It's all about us. So when I tell you this is very real, this is not an anecdotal story that just happened to you, that just happened to me. This is statistically proven that happens over and over again. We get less minutes of CPR, right? When we're
Mm,
diagnosed with breast cancer, oh yeah. So yeah, it's statistically proven that, in the field, how many minutes, when we look at the data that's recorded, like how long did we do CPR on this person before they expired? Statistically, we get less minutes of CPR, right? So, I can tell these anecdotal stories over and over again, how our pain is not listened to, how it's not addressed. It's all on the news now. But you're 110% correct, to the point that in this country, the adverse effects, including maternal and fetal mortality, are threefold more over the other races. So if you're African American, you're three times more likely something bad to happen, or you or your baby to die during birth, without regard to your social economic status. So these are just not women who were unfortunately poor and had poor prenatal care. These are women like you and I who have buku degrees and buku school debt and et cetera, right?
right.
These are women who are well educated, well versed. This happens, and the only common factor is that we tan better than everybody else. Only common factor.
So, in that story, in your testimony, just in terms of being able, like the antidote there, right? Like you pushed, you asked for that clarity in the
Mm-hmm.
question because you could have went home. The average person, to your point, would have went home, but you inquired a little bit more, and that advocating part is, and that inquiry part is something we definitely need to do more for ourselves because I do think that gets the doctor or physician to slow down a second, to actually
Right.
think about it a
You do.
little bit
You do.
more.
And it's important that the general population know about this, because some of these implicit biases were put into our heads during our medical training, unfortunately.
Really?
Um, mhm. So let me just give you an example.
Okay.
Not that we're blatantly in school going, do black people dirty in the ER, right? So it's not, that's not what is happening in medical school. And I went to a very, very good medical school, but along my um training, I was in at some point along getting these degrees, I was in a class, and there was a teacher who was teaching microbiology, and he had a screen up, and the screen said he was teaching us about the statistics of um, STDs amongst different races. Why was it significant? I don't know, because chlamydia acts the same in me as it does Asian woman, white woman. But you know what I mean? So he was saying that the incidence, and he was a microbiologist, you should have been teaching us about the mechanism of the disease state, but yet you're putting up stuff about how you think the epidemiology of this disease state is. And I say how you think, and this is why. Because he had
Mm,
up a slide that said, according to the CDC, there is a higher incidence of gonorrhea and chlamydia amongst the African Americans, then Hispanics were next, and then white women dropped way down here, right? And then he said, and Taylor, I talk way too much, so you can just gear me in another direction at any point. So then he said, the incidence is, this is because of the sex for drugs industry. So I said, whoa, Kimasabi, whoa. And in the sex for drugs industry, he had an article up from Time Life magazine. So we'll assume that the CDC is a reputable organization. We'll assume that Time Life magazine is a reputable publication.
Intertwine everything.
That's right. The intertwined everything. So Taylor, can we stop for just a second?
Perfect. I think we're good on that. We were
Okay.
talking about Black maternal health, those impacts and the statistics, and how um, a medical class became real subjective.
It became
Just in
super
ter-
subjective. So you put two different slides up. One says that Black and Hispanic women, particularly Black women, have a higher incidence of gonorrhea and chlamydia from the CDC. And then an article from Time Life magazine that says the incidence of STDs are increasing in this country because of the sex for drugs industry. So you put those two slides up, and I was so perturbed by this. So when I was in school in a different state, I called my dad, and he said, you really should say something. And when I asked the other Black folks in class, they said, Tamika, don't cause any trouble.
That's
So
what we try not to do.
yeah, don't rock the boat. So I went to him and I said, sir, with all due respect, I just want to see what his perspective was for it. And these were the words out of his mouth. He said, I just want you as young clinicians and physicians to be aware that when certain demographics come into the ER, these are things that we need to look for. I said, so when I, as a Black woman, go into the ER with lower abdominal pain, I'm automatically in the sex for drugs industry, because that's the impression that's the unconscious bias that you just put it in all of those budding clinicians' head. That is what I mean by unconscious bias. So there was a survey done amongst medical students about their perception in pain in Black folks, and medical students, and this was in recent history, less than a decade ago, actually thought that the pain tolerance of Black folks was higher. And
I've
these were
heard that, so that's not a myth. That is definitely,
no. This was a
especially
survey. Not that it was taught. This was a survey that they asked the students. So no, absolutely not. That's absolutely true. So now these budding clinicians have it in their head that if I come in and in pain, hence my name is Dr. Tamika Perry. I'm in pain. I need some help. Here's my differential diagnosis, and this is what I would like. Because you, when you see me, think that, oh, she can take it. She got it.
and so in recent news, there have been two incidents of
Mm-hmm.
mothers,
Yeah,
one down the street from you in
absolutely.
Mesquite, Carrie Jones,
Mm-hmm.
was being checked in while she was giving labor. They were asking questions, had you had a child before? And she's literally, and being respectful at the same time, giving in labor in a wheelchair, and she's still checking her in like nothing's wrong. And then
Mm-hmm.
another woman in Indiana, Mercedes Wells, was turned away and gave birth in a
In
car.
her car. In her car. And this is not uncommon. This happens all the time. Thank God those individuals were dealt with accordingly, but this is not uncommon. This is not uncommon. And it could have happened to me, could happen to you, not just these young ladies. Had that statistically, had that young lady not tanned as well and had a different name, she would have been, the red carpet would have been rolled out for her, and her approach would have been different. And it wasn't, you said she was respectful. I felt like she was nonchalant, almost passive aggressive. Mm-hmm. What's your insurance again?
No, not the nurse or the person checking her in. I
Oh,
was referring to the woman. Like
oh,
her mother
absolutely.
did. Yeah, her mother said, and people were like, "Well, why didn't you go off?" And it was more so of like that situation would only got worse. All I could
Right,
do was document it, and
right.
then the comments were like, "That comes with wisdom."
It
Right?
comes with
It
wisdom.
comes with wisdom. Like we know the game.
Right.
And unfortunately, we have to teach our children that too about these biases and how to move appropriately through them. So I'm glad these two women survived, but what would be the cause to ever turn someone away from? I mean, it wasn't an insurance thing. It wasn't like they literally were turned away and they were in labor. Like,
So you did not adequately treat or check them. There's a simple exam that you can do to see if a woman is in a simple manual exam you can do. Is this lady dilated or not? I mean, it's just as easy as that. I mean, a nurse could do it. The resident physician can do it. The ER doctor could do it. The OBGYN on call can do it. That's in the hospital. So there was no reason besides you simply dismissed what is clearly happening in front of you because you could not get past the fact that this woman tans well. And that's a bias that's here because those same individuals will make statements like, but I have Black friends. I'm not racist.
The exception. I never take that as a compliment. Like, I don't want to
Ever.
be the exception,
I
right?
had a patient who was very upset because someone had accused her, this is many, many years ago, of being racist. And I have a very candid, very honest relationship, very friendly relationship with every single one of my patients. I wouldn't say every single, most of my patients. And so I guess she felt very comfortable having this conversation with me. And she said, I told him, my friend is Black, my doctor is Black. I said, you've never had Thanksgiving at my house. And I've never had it at your house. I don't know what your grandma's name is. I've never watched your dog when you went on vacation. You've never babysat my kid. I'm very professional in what I do. I'm very nice, but we have a professional relationship. So just because I'm your doctor and I'm African American doesn't, and I don't, the same thing if I was your attorney or your accountant, unless we're legitimately friends. I mean, the realm of that becomes, you know what I mean? So
Right. It's
yeah, that's so
different.
it's different. It's different. It's
Yeah.
different. And we can, and I'm not just saying that, and Black people are not bias free. If you have a brain, you have a bias, right? But
Right.
we're talking about biases that affect us where we don't live no more, where our children don't live anymore.
That. So getting in the topic of children, right?
Mhm.
So I'm just kind of relating this back to my story. I found the third time is the charm, found the right physicians.
Of course.
Even had some trouble in the delivery room. I lost a certain amount of blood, but she was right on top of it, right?
Mhm.
Like, doctor did whatever she did to make sure I was okay. And when the baby was born, her bilirubin like
Mhm.
tested a bit high. And so I had to actually come back to the hospital for a test and so forth. So that was that physician following up with that treatment.
Mhm.
But there have been instances where there's kernicterus in
Mhm.
children. And what is that impact? Like when you get the poor maternal health and then you turn it over and the child's born, what are some of those impacts and illnesses and things that women should watch out for?
Well, let's talk about what kernicterus is. So kernicterus is also known as bilirubin encephalopathy. So bilirubin is the byproduct of old red blood cells being broken down. And when babies when they come out, they still have some cooking to do, right? So their liver isn't quite formed yet. Their lower esophageal sphincter, that's the door between the food pipe, the esophagus, and the stomach isn't formed yet. That's why little babies spit up a lot, right?
Okay.
So yeah, that's why little babies spit up a lot, and old school mamas will be like, "Put some cereal in that food," and that's just to
Oh,
keep
they
the food
do.
down. Oh, girl, from day one, put some cereal in the food, right? So you've heard it from your mama, right?
Yes.
When you had your baby, because my mama's favorite term when I had my baby, and mind you, my baby's 20 now, but my mama's favorite phrase was, "I know you're a doctor, but," so she had everything for me to do, right? So anyway, so bilirubin is this byproduct of red blood cells, and you and I, whoever a functioning liver, we get rid of it, no worries. But if that bilirubin is left in the blood, what it can do is it can travel to the brain and cause this encephalopathy or pathology, swelling of the brain, that can lead to poor feeding, poor sucking of the baby. It's hard for them to latch on. They have poor muscle tone, and in severe cases, you're left with a kid with a severe disability. Now, the good thing is that kernicterus, if we were to normalize it over all populations, only happens to 1 to 2% of the population.
Mhm.
However, or 1 to 2% incidence of it. However, when kernicterus happens, 25% of those cases are in children of color, black kids.
Hmm.
But 14% of all births are in this country are only of black kids. 86% of the births are other. But 25% of kernicterus happens to us. And so you have to ask yourself again, why does this happen? Well, it was taught in school, in residency training, that the incidence of kernicterus, or this immature developed liver, is less in children of color. Now, where did they get that data from? I'm not sure. So these assumptions are made about a lot of things that have been debunked over the years. Another side example is that for years that we were taught that there's a separate equation to calculate something called the GFR, the glomerular filtration rate. That's the speed at which kidneys filter blood to make urine. There's a different equation for Black folks and different equation for everyone else. And the
Hmm.
assumption was is that because that calculation, it's a speed, it's like miles per hour, right? So it's actually calculated based on blood values, height, weight, protein mass, and it was assumed that Black folks had more protein mass, more muscles than the general population. There's never been any studies over that.
No.
There's never been. So that was just an assumption. That was a bias that was made that was based on a bias. So for years, Black people were left off the transplant list because our GFR looked like it was better than everybody else's.
Or
So
move down further on the transplant list
uh-huh,
and then
mhm.
succumb to
For
whatever.
based on a equation that has a bias built into it. Now, if we go back to the babies with connectorus, I challenge to say now how we figure that we don't get it as much. In fact, some studies suggest there's an entity that we have called G6D DP deficiency, PD deficiency. And if you have that deficiency of that enzyme, there's certain medicines you can't take, there's certain things you can't do, and you may actually be at risk of connectorus. And we have it a little bit more than the general population. Secondly, if you are not an astute clinician, we come in all shades of wonderful, right? We come in all shades of wonderful, light bright to midnight blue. If you are not astute enough to look and say, I can't tell that baby has jaundice, because one of the side effects of bilirubin not being excreted in the urine or the poop or through your system is that it deposits underneath the skin and the baby will have a yellow hue. Well, the baby's eyes will also have a yellow hue. The baby's hands will also have a yellow hue when these are areas that are typically melanin deficient. So we're not just we're doing a real physical exam. We're not just glancing at the baby's skin. You need to look at the hands, the bottom of the feet, the eyes. In addition to that, you need to measure bilirubin levels. What happens a lot is before, there's like you came back, you got the measured, then you came back to get the measured again. It doesn't happen in Black kids a lot because why that assumption is made, I don't need to. They don't get that. Yeah, we do. Why is my body different? I do.
And I had no idea that there was, I mean, I'm kind of glad I didn't know
Yeah.
that there would be a mental impact because that would have been a rough 24 to 48 hours. Like,
Mm-hmm. Mm-hmm.
so the signs, so as a mother, right,
Mm-hmm.
advocating for your child,
Mm-hmm.
levels are high. What is a high level in terms of when a number or read comes back? Is there something, I mean, other than the physical
No, this is
observation?
no, this is what you're going to look at as a mom, because in a realistic sense, you're not going to see like you're not going to see the labs, and you're probably this is what I want you to look at as ask as a mom. Ask what is my baby's level and what is the control normal for this hospital. So let me give you an example. If bilirubin normal goes from 1 to 2, that's what the textbooks tell us. Each hospital, each lab has their controls, and in this hospital the normal might be zero point 0.8 to 1.9. You see, it's still close to that realm, that what the average is. So you want to ask, what is the normal for the controls in this hospital, and what are my baby's levels, and when are we going to measure them again? This
Mm.
is the age of information, and we can arm ourselves. I know doctors hate it when patients come in and they become Dr. Google.
WebMD, the WebMD patient, they
Oh
don't like
my.
us.
Oh my. So, but that's okay. It is my job. I tell people all the time, it's just my job to educate and disseminate information. So let's break some of that down. Let's see what's real and what's not real. Because a lot of times people go to Dr. Facebook or Dr. Instagram, right? And it's not the best source of information. So one, you want to even arm yourself with the thought process of, can you check my baby's bilirubin? How many times has it been checked? And almost when you start to leave, usually you're there a day or two, then you leave the hospital, right?
Mhm.
You're going to notice, why isn't my baby feeding the way it I think the baby should be feeding? Why aren't they latching on either to me or to this bottle the way that as a mother, I know they should be latching on. And if you have any indication that something ain't right, go back. Go back. Patients tell me all the time, I know my body. You're absolutely right. You've been with your body your entire life. You know your body. I know science and medicine. Let's come together and see what's in the best interest of you. I do not like it when my fellow colleagues got hated when patients say that, but they ain't lying. They know their body. They've been with their body their whole life. So it's my job to listen and see what you're trying to say medically. When you
Mm,
describe something to me, how is this applicable to what could be going on with you from a medical standpoint? That is my job, right?
that,
And if I don't know, then it's my job to refer you to somebody who likely will know. Do you see what I mean? So
yes.
it is not the job of the mother to be a baby doctor, right? It's not the job of the mother to take out a second degree. And we should, as Black folks shouldn't, but we should arm ourselves with education. One, this is the age of information. And two, not be afraid to advocate for themselves. I have a lot of older African American patients who say, yes, ma'am, bow their head and everything to me. No, ma'am, ask me lots of questions because they think that what I say is absolute law. But you have the right to ask questions if you don't understand. That is what you were there for, right?
Right. And that's
That
a
is
generational thing too,
it is a
right?
generational thing.
Because
And I've had
we're,
some
yeah.
no, it's absolutely, especially amongst us too, because I've had some older patients who actually switch from me to my partner who is very culturally in tuned with us, great clinician. In fact, my stepdad goes to him and he's Caucasian, but their sole reason from switching to me to them is, and they will say this, is that I just, and these are older individuals, 80 plus, I just didn't know about the Black doctor because in their head, that's a bias that we have, right? Because
Oh,
in their
yes, they
head,
must be, yes,
white
Asian
is
or
right,
Caucasian. They must be just a little bit
little
smarter.
bit,
They
yeah,
must know a little bit more.
yeah, like I'm the
Yeah.
imposter, like like they've given me imposter syndrome, right? You know what I mean? Like, and he will say, she's my boss, right? She is my boss. So,
That's funny,
yeah,
but I totally I get it. And it's just one of those things. You just like look, you just shake your head.
you
You're
just
like,
shake your head
okay.
and say it is what it is. I'm not going to win them all, so let, let me go on to the ones that I feel like I can. We can have a conducive, productive relationship. So biases happen on both sides. But the point is, we have to realize that we need to arm ourselves what's in our best interest. And if your clinician seems like he's upset or he or she is upset or perturbed because you're asking questions, that ain't the one for you. And that ain't the only kid on the block. I mean, you went through three, right? OBGYNs,
Three.
yeah. Yeah.
And one of them looked like me.
And that happens too. Because remember, when I was sitting in that classroom, there were, even though it was 250 people in that classroom, 8 of us were African Americans. 6 of the other 7 told me that I was don't cause trouble. So that bias settled into their heads too.
And that was
So
taught to
we,
us from the other generation.
mm-hmm,
Work hard, keep your head down,
mm-hmm,
and don't rock the boat.
don't
But
rock the
you
boat.
know, but the boat rocks whether as long as you own it, it rocks, no matter what you
That's
do.
right. That's right.
So,
That's right. That's right. That's right. So we just have to be aware that this happens to us. I think a lot of that this is just anecdotally. I feel like this is why a lot of my patients look like me because they specifically seek out a provider that looks like them because they feel like at least someone can hear me or understand me culturally. When I have residents and I mentor a lot of residents, I have a lot of residents and medical students in my office, and I let them know. And many a times the residents and medical students do not look like me because we're just in the minority in this field, right?
right.
I tell them, I says, no matter where you practice, you have to be culturally in tuned with that population. The population isn't doing you a favor by servicing you; you're doing them a favor by servicing them. So, or the other way around. Yes. So they're doing you a favor by patronizing your business.
Right.
So you have to be in tune with that population. So I say this because the outcomes are always better. And the government actually has these statistics here. Provide patients who are served by a provider who looks like them have better outcomes.
So that's definitely very true. I wonder if most doctors actually encourage like community involvement for you to totally be in tune. So in a non-related subject, volunteering with my sorority, Delta Sigma Theta Sorority Incorporated.
Okay.
The first, we would host police academy when they graduated. They would come into the community. We would invite all the leaders so they could see people. Believe it or not, these people were coming to serve in the community, and they had never talked to a person that looked like me.
Mhm.
So does that happen in the medical field in terms of
Absolutely.
these people that are being, they need to be in tune with the community? They grew up in a rural area. They maybe didn't even have that one black friend they could say. Does that happens in the medical
That
community?
happens, and what I encourage, like I like one, I give my one of my partners credit in my office now, that he goes to the churches when invited. He goes to speak at community events.
Hmm.
He's learned to love soul food because he was like, this is the population that I treat. So I have to know what's going on with the population. So if I were to say to him, oh, my kitchen is itching back here, he knows what I'm talking about. And that's how in tune you really should be. So when I work for a big company now, but when I was in private practice, for almost 10 years, I had three practices, and one practice was in a low socioeconomic area, i.e. deep in the hood, mainly black and Hispanic, mainly black, probably about 85% black, 5 to 10% Hispanic, and the rest was other. I had a practice that was in a suburban area of Dallas, and it was a suburban area about 60% of color, 40% other. And then I had a practice that was near, adjacent to downtown Dallas, that was affluent and mainly Caucasian, and then heavy LGBTIA population. So each population, I did my best to respectfully code switch. I was somebody else in each population. And when I say that, because I went to, if my patients invited me, I went to events in the LGBTIA community because I wanted to see the perspective, and I wanted to make my interaction with that patient better. I wanted to have a connection with them. So when my patients invited me in my hood clinic to their family cookouts, and if it was appropriate, I went. When my patients in suburbia would come in with medical context and things to read, I would read them. We read it with them because I need to serve the population that serves me.
I'm sorry, Dr. Perry, but no matter what school you go to, you can't teach empathy. And
You
so
can't. You
you
can't.
can't. And that's just in bedside manner. So I appreciate you for your services, and I'm glad you are mentoring people and up and coming doctors that look like you and don't look like you so they can continue to be an advocate and exude empathy because that's really what's needed.
Absolutely, absolutely. Even if sometimes the patient is um, asking for something that is not medically appropriate or necessary, sometimes that conversation goes so much smoother when you are empathize with that patient and they know that you have their best interest in mind. Like we can do that test, but we really don't need to, and this is why. These are the reasons why.
That I
X, Y, and Z.
appreciate. Yeah.
Yeah,
'Cause
these are the
I'll come in
reasons
with a
why.
list of tests that I would like.
Right, right,
Yeah.
right.
Saw that
So
commercial. I watched the story. I think I have a symptom. Oh no. Yeah. Like a bit of a hypochondriac. I totally get that. So just putting a pin in
mhm,
um carnivorous in
mhm,
terms of symptoms, like
mhm,
the levels, get a baseline level from the hospital, compare
right.
that to your baby. What are the checkpoints? How often are we going to check till we make sure it's below level and we're at a good stable there? And then also checking hands and feet, um,
Mhm, mhm.
those
Hands,
areas,
feet, pupils.
non-melanin, okay, and
Mhm.
pupils, non-melanin areas to be able to advocate for your baby in that. And then obviously knowing the long-term effect. Oh, and don't forget latching, because now that I think about
Yes.
it, my daughter did have trouble latching. I went to a lactician to be able to work through that. But now that I think about it, going back to the hospital to go check for jaundice again, that went hand in hand. And that's something I didn't know to today, and she's 6. And I had learned that from you. So thank you for that. In addition to not receiving, like the trickle down effect from, not receiving that proper maternal health, impacting the baby. Another issue in terms of Black women face a disparity in is sickle cell,
Mhm.
right?
Yeah.
So there's not a lot of research and drugs and things of that nature. Can we talk about that a little bit in
Yeah.
terms of,
So
go ahead.
Yeah, let's talk about what sickle cell is itself. So you know what a sickle looks like, right? It's kind of a C-shaped letter.
Mhm.
Typically, we think of it, being attached to like a blade. So it's a C shape. So it's sickle cell because the red blood cells are shaped like a sickle, and normally red blood cells should be nice and round. And what happens in there, that hemoglobin, that's the molecule on the inside, is abnormally formed, and so it causes that sickle shape, and that hemoglobin can't attach oxygen to it like normal hemoglobin would. Now, the scientific reason that is proposed that people of color have more sickle cell is because um, countries where people of color are typically from, Western or Africa, but particularly we're talking about African Americans, so Western Africa, Southern Mediterranean, those areas are plagued with malaria. And
Mm.
so what happens with that little parasite, that little fly, its little babies, this little byproduct, when it stings you, it goes into the actual red blood cells themselves. It attaches onto that molecule and it causes hemolysis or explosion of that red blood cell. So you can't obviously have all your red blood cells dead inside of you. That's why malaria can be really, really bad. So over time, this is what's proposed, a protective mechanism came along where if some of the cells are sickle, it can't latch onto them, right? So,
Mm.
and this is, this is what's thought to be in science. So the reason why we have it here is because where did they get us from? That part of the country, that part of the world, right?
Right.
So fast forward to, you say sickle cell. What's happening with sickle cell disease? Well, in order to have the actual disease, you have to have at least, one or both parents have to have either the disease or the trait, at least the trait. And then they make a kid, and there's a chance that that kid will have full-blown disease where all of their red blood cells have the ability to sickle, but they sickle in environments that are oxygen deficient. So oxygen deficient, or get worse in oxygen deficiency, extreme weathers, like when it gets really, really cold, when there's a high oxygen demand, like when you're running track, like the kid with sickle cell probably is not going to run track because your body
Mhm.
has a high oxygen demand in, right? You go up in the mountains,
So I'm like,
you know,
Colorado wouldn't be the best place to live either. Yeah. Okay.
no, not in the least little bit. So you can have a sickle crisis at that point because these red blood cells, what happens is they turn into this sickle shape. And then when they go through the very smallest of our arterioles and capillaries, very smallest, they get caught up in there and causes occlusive syndrome. And I mention this now because it's going to be relevant to a particular drug that we're going to talk about. But it causes an occlusive syndrome where it blocks it up and causes this extreme pain in the chest, pain in the joints, pain all over. Now, historically, the treatment for sickle cell has either been transfusions, things to help you, try to help you that cell not sickle, and pain medicines, straight up pain medicines.
Oh,
Pain
wow.
medicines like morphine, oxycodone. We're talking about heavy, heavy pain medicine. So what is
In
this pain
everyday
medicine?
life, you just walk
Every
around
everyday life.
on
So
oxy.
so
Okay.
and I'm glad you have that the expression on your face, because what happens is we have these kids with sickle cell. We pacify them with fluids. We pacify them with some drugs that kind of work, and pain medicine. And of course, now you feel better. The mechanism of action is still there. The underlying mechanism is still there, but you feel better now, right? Everybody feels better on oxy. So, so
Okay.
you feel better. Now you can get up and walk out of the hospital. But by the time these kids become 18, they're effectively addicts.
Yeah, if you've been
So
taking Oxycontin since
they're in and out. Sickle cell patients as an adult are very difficult to treat on a primary care level because what their body and science has taught them is, I just want that pain medicine, to the point that I've had one in the hospital where, we can give you a pump that monitors how much pain medicine goes into you, and it has a lock on it. So you can't give yourself too much. So you can't accidentally overdose, right? This young lady broke the lock on the pump. I don't know how she did that. It was digital, it was electronic, but I'm like, clearly you're intelligent because you figured out how to do this. But it's not, and then everybody is mad at her. They're mad at people at sickle cell. Why are they addict? Why are they doing this? We made them like that. We did that. And
wow.
now after the fact, you're mad at these individuals.
Mm.
Nobody wants a sickle cell patient as an adult because they go in and out of the ER, drug seeking, legitimately drug seeking, because that is a treatment that I've told them that's the best treatment I've told them I have for them in terms of controlling their pain. And we've done that to you since you were a little kid. And now society wants to throw you away. Medical society, right? So there was a drug that came along, Oxbrita, made by Pfizer in recent history. And it actually got pushed through early because they said the benefits would outweigh the risk. So we don't have to go through all the clinical trials. And what it did was it prevented those vaso-occlusive episodes. Remember, we talked about the mechanism of action was to, um, you know, to have that cell become that sickle shape and it
Oh,
couldn't
that's
get through
so.
that
Yeah.
round pipe, right?
Right.
So this drug allegedly help prevent that from happening. Oh my God, somebody has finally addressed the mechanism of action. So we're hopeful, but we do, or the FDA does look at real life um, outcomes. And when I say real life outcomes, when you go into a study, and once again, you're going to have to, I talk way too much, but when you go into a study, or when an individual goes into a study, it may be 10,000 people in a study, and studying 10,000 people over time against a placebo still doesn't capture everything when it's released to millions of people.
Right.
You see what I mean?
Sample size. That's not. Yeah.
Sample size. That's exactly right. So the ultimate sample size is the general population, right? So it becomes kind of a dichotomy because I want to encourage us to go into medical studies, but we have reason to be fearful to go into medical
Yes.
studies.
I went to Tuskegee University, and
Yes,
everyone thinks about Tuskegee in the research, right?
that's right. So it becomes a dichotomy that you can't really I can't really argue with, right? And for just on a side story, me and my younger sister is a physician too. And before
Okay.
my grandparents passed, I would always say, "Oh, Papa, you need to get your flu shot." He said, "Chew, baby girl, you're not putting that mess in me, and I'm his grandbaby." Like he's my favorite person in the world, right? So he was adamant that because he remembers Tuskegee, he was living during that, right? So
Hmm.
so it becomes this dichotomy. So we had this study that was done, and it looked like it was going great. It looked like it was going great, but when it was out into the general population, they actually showed that people were dying at higher rates, and they had more vaso-occlusive episodes. So it makes you think that one, maybe we shouldn't have pushed it out so early. And
Right.
two, why did we push it out early? Was it because of the miracle drug, or was there a secondary gain, monetary gain from the pharmaceutical company?
Probably again. I have some friends in the do medical marketing. And the bonuses look really nice because,
Yes.
yeah, the margin. I mean, it's a 50 cent, and you're selling it for a couple $100 per pill. So, question on that: what were the impacts? Like you said they were dying at a higher rate.
Yeah,
So, did you succumb to sickle cell? Like, what was happening?
yeah, the sequelae of sickle cell itself. So you think you're being treated, but you're not really being treated, right? So it's the sequela of what happens during sickle cell that was causing the death. Now, mind you, I'm not saying that the drug does not work because it was a voluntary recall. And so, you really have to weigh your risk benefit ratio if this wasn't for me. But everything ain't for everybody. And that's the point of studies to say, is this drug for most people? Is the risk benefit ratio, does it make more sense to take the drug? And the risk is this small, but the benefit of this is this big. And that's what we have to do when we do a study. What is the risk benefit ratio? What is the likelihood that a side effect is going to happen versus the intended outcome? And even if a drug has been approved, it is the responsibility of every clinician to do that every time we either write a prescription or suggest the medication.
Are there any
Every single
long-term
time.
effects? I'm sorry.
I
Anybody
was
that
like,
still is on the drug, like that, I mean, obviously recalled, so it's no longer in market, but
yeah,
if they had taken it and they survived, right? Are
that's
there
that's
anything?
difficult. That's difficult to say. So we're going to know that like 15, 20 years from now. That's
Mm,
if the patient is still alive, that's what we're going to know years from now. So that's when we do something called retrospective studies. We look back in time to say this population who had this disease state but was on this particular drug, what commonality did they have and what were their outcomes? Do you see what I'm saying? Just like when the
yes.
drug fen was out, which was a combination of two diet medicines together, people were getting valvulopathy, which is a pathology of your heart valves, having heart failure, and dying. That we learned that way after the fact. We knew
Right.
something was going on, but we learned it way after the fact. And when a voluntary recall was like, stop that stuff now. Yeah. Yeah.
Okay, so they won't know the impact of it, but at the same time, if they've taken it, yeah, they won't know for 10 to 15 years, but
Yeah.
they may see symptoms earlier. And what would some of
They
those
may.
symptoms look like
Yeah.
in
Yeah,
terms
they
that
may
your
see
body
them.
wasn't
So
responding?
the way that the drug works, you may actually see some jaundice, you may see some, long-term intermittent pain, but that's kind of hard to tell because why, you can get those situations with sickle cell too.
Right. That's
Yeah.
very unfortunate.
It is unfortunate because it was something like, oh, it's finally addressing the mechanism. There are other disease states that, get due research, right? Like Huntington's disease and diseases that, but this doesn't affect the minority, it affects the majority, affect the majority male, white males. So other diseases will get their due process in research, in medications, but disease states that happen to the minority in particular, and then this is just my opinion, this is not, statistically validated, is that they don't get their due process in terms of, let me find out if I can fix that. And that's what I mean by due process. Let me find out
And it's
scientifically
a
if I can
long
fix that.
process in
It
terms
is a
of
long process.
research and funding. So my friend, she is a PhD and a researcher,
Hmm.
and she has been able to study fat cells and so forth. But she's telling me about, like, with recent funding cuts, certain things are definitely being chopped. So if this was something that wasn't being studied already, and there's not a lot of research and dollars and grants going towards sickle cell, why do you think that may be?
Well, let's just digress for a second. And if people don't think that medicine in this country and the delivery of medicine and the payment of medicine, I mean, when I say the payment, I mean like Medicaid and Medicare, is not political. You got, you were so misinformed. You were very misinformed. So, unfortunately, politics and for the general senior population and the general under of funded children population being with Medicaid, you're and let me just add the veterans into there too. Your delivery of medicine has to do with politics and public funding. So if certain things are just not going to get attention because there's just not either an interest because of that population or simply the money for it. And unfortunately, with our current administration, if it's anything to do with the non-majority, funding is going to be cut.
That's very unfortunate, and I think some people are figuring that out the hard way.
Mhm.
But I'm not a "I told you so" person, because I think at the end of the day, everyone deserves to be treated fairly.
I do
So,
too.
so I just really hope that everyone gets the attention and they realize they need to advocate and not vote or do anything against their own best interests,
Hmm.
because that's very sad.
Hmm.
So, that being said, this is great information, and I have so many more questions and topics that I would like to get into. Breast cancer, a little bit more about prenatal. What does that look like for Black women? Other diseases impacting Black women or women in general that we don't think about, like silent killers, like pancreatics, like definitely, I think there's a lot to unpack here. So,
There's a whole
if
lot,
you're
yeah.
willing, I would love to have you back on so we can do another session
Absolutely.
on Her
Absolutely.
Health Talk.
Yeah,
Okay, great. And thank you so much for your time today.
absolutely. I really thoroughly enjoyed it. Thank you for letting me ramble on. This is where I feel my space is. So I thank
You
you.
call it rambling, I call it learning. Like, I have a whole thing here in terms of other insightful questions I have. And then as we start to share more content and have more conversations, I'm pretty sure others do too. So that's what this forum's for. And thank you for helping us unlock it with our first talk.
No problem.
All right, have a good one.
All right, you too.